you all for having me. This has really been a fantastic conference. I really am so appreciative to be here. We all walked up here and said complications, and then I realized, was I supposed to present complications? I got extreme intervention, so I was like, all right, let's do something that's complex, but I wouldn't say, well, the problem is I never had a complication my entire life. No, I'm joking, but honestly, but it's not. And when I looked at this, I saw extreme interventions, and I saw, okay, we've got a series of case presentations, and what I wanted to do, I saw I was case one. So I was like, let me do, this is a complex case to undertake from an endo standpoint, and I wanted to go through, how we can utilize our basic sort of tools to work through a case that would otherwise be considered, hey, maybe this isn't something we should do endo. So that's really what I wanted to show here. So I'm going to present to you. This is a 67-year-old male. This is actually relatively recent. This is only a few months, maybe 7 months ago or something like that. CLI patient had a prior intervention outside hospital. 2011 on the contralateral leg, actually. COPD, hypertension, coronary artery disease. Non-healing ulcerations, right anterior shin. Really can only examine the guy with his leg sitting on the ground, so you can already tell things are pretty bad. CTA, I'll show you very briefly. He's got a right common femoral artery occlusion, an SFA, maybe hibernating segment with another distal occlusion, a pop occlusion, and then some tibials that maybe come back on the CTA. Our plan in our practice, so I run a practice of, we have 11 IRs and 6 vascular surgeons, so we talked to our surgical partners and said, hey, maybe he needs an endarterectomy and a bypass. He was felt to be a poor surgical candidate for all the reasons I just stated above. They weren't crazy about doing this. I think he didn't have usable vein on top of that. And so they said, hey, maybe you can do something endo. We get it if you can just open the common fem. Maybe that'll stabilize things for this gentleman, but he's obviously in a bad way. This is if you show the CTA. Oh, you know what? He had an iliac stent in place, so that's from that prior intervention. And if you look here, it's a little hard on the timing. Maybe I can drag this through. That common fem, that's all calcium right there. So he's got a common fem occlusion from calcium. And then he's got some reconstitution of this SFA. And then it kind of occludes again, distal SFA through the pop. This is all occluded. We're looking at the right leg here. There's some motion there. There's a big rock in his P2 pop there. And then it probably comes back somewhere around the prox tibials. And we think the AT is at least the dominant runoff there. So this is what his leg looks like at the time. He's got, I call this R5/R6 disease. I mean, it's not a massive amount of tissue loss, but he's obviously ulcerating, in the Achilles region as well as the dorsum of his foot. Again, this guy can't sleep without his leg on the ground. I thought they were all pretty superficial, actually, ulcerations, so I thought this was like a perfect time to re-intervene if we could open this. Non-palpable anything from his common fem through his tibials. ABI was 0.28 on exam. He's got these ulcerations we just looked at, so he's basically R5, R6 CLTI. This is his angio, so I went and left up and over approach. You can see the common fem occlusion, there's the profunda, and then we got some reconstitution of this SFA with some islands there of recon. If you go distally, this is like mid-thigh here. We're bringing back a little island of SFA. We then occlude again. So I always find these are pretty complicated cases when you have these like tandem areas of reconstitution and occlusions. They can be kind of tricky. If you go below the knee from this common fem shot, you have this one like geniculate or so collateral. Maybe we're bringing back an AT there. It wasn't great. It almost looked like a pseudo like ALI picture. The flow was so bad, but that's what happens when you have inflow occlusions in this setting. So I came up and over, tried to cross with my typical, I use the same thing every day. I joke, I say I stir my coffee in the morning with an 014 glide wire advantage. I just always start with that. I find it gives me some tactile feedback on the lesion, and then I make choices from there of what I need to do. So I try to cross this. I thought there was a little microchannel when I inject through my support catheter, like maybe I can wire that. I spent a good 20 minutes thinking I could do that, which is unlike me to spend 20 minutes to do that, and I still couldn't wire through it. So I decided just give me a weighted tip wire and let me just try and just punch through the thing. I thought it was pretty well centered. So I did that. I used a 30-gram Victory in this case, and then punched through, and I'm back in the true lumen of the SFA in this sort of hibernating segment of SFA with these multiple boulders beyond. I put my 018 catheter back down, and this is that secondary occlusion we talked about here. At this point, though, when I inject, I actually can get some tibial reconstitution, so I started to feel pretty good. about this. Again, it was the idea was, hey, Nick, if you can just get that common fem open to profundable stabilize things. But I'm like, I'm just going to open the whole thing. I think it's totally fine. I just got to get this pop open as well. So I go down the pop, I try to cross through that. I showed you that big rock on CTA, and that was tough. So I'm in a subintimal technique. I don't know if you can see here, I have my jade wire and my support catheter, and I'm just not re-entering. So, at this point, I'm thinking, all right, I have no problem when I have one level of CTO to do a retro and a cart and things like that. When you have multiple levels, that's when it really starts to get tricky. But at this point, we've already taken that out of the equation. So I came back up from the PT. I thought that was sort of the worst runoff. So I could see it on ultrasound. So I stuck his PT. We talked multiple, or even earlier times of the session I was in, cart and reverse cart. So this is I just think very basic techniques on this X point. PK, you were doing that case earlier. We were talking about cart and reverse cart with looking at that X point. So I think it's really an important concept to understand. This is my awesome. I had an artist draw these for me, but so this is kind of the way I picture it. But you want to look for that crossover point between the two wires and bring a wire up. Balloon up from one way or the other balloon. If that doesn't work, you go to kissing balloons. If that doesn't work, right, you do a balloon-assisted reentry, right? And so in this case, you can see my antegrade wire coming down. You can see both wires start to go in different subintimal tracks. I found that X point. I brought my balloon in from below, balloon that, slide my wire down, find that tract, and then we dilate the whole thing up from the antegrade. This is what it looks like after the cross. You can see that that's I want to draw your attention to this. That's a popliteal artery. Look at the size of this thing. It's like 3 millimeters. We're going to look at this later because it's kind of interesting to me anyway. And this is that pop cross across that rock. You can see we're in a sub-I position across that whole rock. So we know we're going to have to lay some form of scaffold, across this. And then we find our way, again, this is back into the SFA lumen. Again, it's a relatively hypoplastic SFA, but we're definitely true luminal with a lot of disease there. And then we have our common fem sort of at the end, that common fem occlusion right here that we punched through. I had some difficulty exchanging anything after that point because I was so far down. I had that common fem occlusion. So I brought we did IVL on this. We brought a 660 M5 plus shockwave balloon. Delivered those pulses. I won't bore you with that. And then I followed that with a Ranger DCB at the same time. Had a pretty reasonable result. Even by IVUS, I was kind of happy with how that looked. And then I in this case, whenever I have a CTO that basically goes from the groin across the knee, I use what I call a subuvia, which is basically a supera funneled into alluvias. That's why I think they've served me pretty well over the years. So basically, we went from the pop through the SFA origin, and then again, we DCB'd that common femoral. Here's the result we had, which I thought was a very nice result.
Beautiful case.
And SFA, that's through the superas there. The kind of really interesting thing about this, which was kind of cool in my opinion, is like, look at the size of this step off. And my young associate was with me at the time, and she's like, you're going to put a 5 in there. I'm not a big believer in 4 or 5 superas. I think they don't stay open that well. So even though I realized that this vessel is super tiny, I thought it would plump up over time. I thought it was just some negative remodeling. So this is what it looked like on my step off. So I put a 5.0 supera into that like 3.5-ish millimeter artery. Here's the runoff. I always tamponade my retrograde access shut, so there's a little bit of spasm there, but the runoff's not bad, nice and intact from our retro stick. This is the IVUS post. I won't play the whole thing for you, but you can see through that stent construct we had a pretty nice stent expansion, a little bit of extrinsic compression, but nothing that I would say was too horrible. And at the end, you'll actually see the common fem had some that's the common fem right there. It really was not too bad. I thought we had a really decent result for being that degree that we were talking about an end dart. So he did extremely well, resolution, rest pain, wounds healing, reperfusion. He actually had wounds on his other side from the previous intervention with ISR. And so when I brought him back, this was 3 months later, I was dealing with the other side because it was a little less. You could see that in 90 days he's healed his wounds extremely well. And at that time, which I thought was super cool, I said, let me run off the right leg again when I'm going up and over to treat this left ISR. So this segment right here, I just thought it was a really interesting learning experience. That segment right here, that's this right here, 90 days later. So you can see that, that negative remodeling has really grown to sort of, accept that amount of flow in such a short amount of time. I just thought that was really impressive to see that change. That's kind of crazy. And it's nice to see that angiographically. All right, so in summary, again, I didn't have a great complication to show, but hopefully it's a nice, basic, complex case to kick us off for this session. R5, R6, CLTI, basically common fem through below-the-knee disease, and we use a variety of techniques, weighted tip wires, retrograde, safari, cart, and we treat it with a combination of IVL, woven stents, drug-eluting stents, DCBs, and we ended up in a successful limb salvage. I'll keep us on time.